Hi everyone, my name is Claire Jonas. I am the Research Communications and Engagement Lead at the Stroke Association. And today I am hosting a webinar and Q&A with some members of the Stroke Association funded GHOST team. So just to give you a bit of context on GHOST, around 1 in 2 suspected strokes are eventually diagnosed as stroke mimics. So that's conditions that look like strokes but aren't, something like a seizure or a migraine. That is no surprise, that statistic, if you've worked in this field. Signs and symptoms of stroke like arm weakness, difficulty speaking, headache, they all overlap with other conditions. And making a wrong decision about stroke can be fatal, so it is best to be cautious. What if there was a test that could say within minutes whether a patient really is having a stroke? Even better, what if that test could say what kind of stroke it is? Those are the aims of the Stroke Association funded GHOST project. Just to set expectations for this webinar, this is mainly intended for healthcare professionals involved in the GHOST project, but everyone is welcome to join us. You're welcome to ask questions in the Q&A section at the end. We've included plain English explanations throughout, but please be aware that there will also be times when we'll go into a bit more technical detail. So I'm going to hand over to the GHOST team to introduce themselves. Hazel.
Good afternoon all. Yeah, my name is Hazel Smith. I am the Portfolio Manager for the Research and Emergency and Acute Care team at the Queen Elizabeth Hospital in Birmingham. We are delivering the GHOST study.
Thanks, Hazel. Josh?
Hi everyone, I'm Josh Miller. I'm a paramedic by background, lead research paramedic at West Midlands Ambulance Service and leading on the GHOST study at West Midlands Ambulance Service.
Thanks, Josh. And finally, Tony.
Hi everyone, I'm Tony Belli. My background is I am a neurosurgeon, actually specializing in trauma, and I'm a Professor of Trauma Neurosurgery at the University of Birmingham, and I'm the principal investigator for the GHOST study.
Fantastic, thank you, Tony. We were also due to be joined by another member of the GHOST team today, Dr. John Hazeltine, but unfortunately he is unwell. That might mean we finish a little bit earlier than we expected. So we're going to go through 3 segments of presentations from Hazel, Josh and Tony. You can ask questions in the LinkedIn live chat anytime, and when we get to the Q&A segment at the end, we will respond to as many as we can. So Hazel, you're going to kick us off telling us a bit about how GHOST came about and why it matters.
Thank you, Claire. Yes, the GHOST study stemmed from a trauma study that we've been running here for a long, long time. I'm afraid GHOST is now my fault. Apparently it was my idea. Just to give you some background, we are here at the Queen Elizabeth. We are a major trauma centre. We're also the hyperacute stroke unit. And the team that I manage, we link both together. We run studies in both specialities. So the Golden Hour in Stroke study, which is what GHOST stands for, is stemmed from our Golden Hour trauma study. This involved taking pre-hospital blood samples initially and then saliva samples since 2021 from major trauma patients, looking for biomarkers for traumatic brain injuries. This was very, very successful. Tony will fill us in a bit more later on about the SCRUM study, which identified those biomarkers for concussion, and that's ongoing work that he's doing at the moment. But in a random conversation, one day we just thought, well, actually, maybe can we look for these biomarkers in stroke patients? It's still a form of brain injury. It might be a different cause, but it's still a brain injury. So that's where the idea came from. And we put together a group of people with the correct expertise and then had the wonderful funding from the Stroke Association. So thank you very much for that. So our main aim is to see whether we can identify biomarkers in patients that tell us that that patient's had a stroke versus a mimic. That's our overarching aim. As many of you all know, mimics are approximately 20% of patients who the ambulance crews go out to and suspect they're having strokes. So that what we could do with that information, if we can identify through saliva samples by the patient's bedside if they're having a stroke or if they're having a mimic, could make really big differences to the treatment pathway that those patients go through. We've all heard the right place, right time mantra for getting patients where they need to be as quickly as possible. We also know that brain equals time. So though if we can identify by the patient's bedside exactly what's happening to them, then we can change our decisions, change our patient pathways to fit. Our next thing would be, if we can possibly do this, is to be able to tell the difference between a hemorrhagic stroke and a ischemic stroke. This obviously then has massive impacts on the patients. At the moment, any treatment that's given to patients is very minimal at the scene, because we can't say either are they having a stroke, or then B, what sort of stroke it is they're having. So it may be possible that if we can get to that stage, which would be our platinum standard, would be that we could then say, yes, they're having a clot, or yes, they're having a bleed, and therefore the ambulance crews could carry the right treatments and be able to treat the patients by the bedside much, much earlier. I didn't mention it earlier, but I'm a paramedic by background. I've been there, I've seen those patients. I understand the frustration when we're there and you've got somebody that's clearly very, very poorly in front of you. And yes, we've got blue lights, and yes, we've got experience, and yes, we've got wonderful facilities like our HASU here and other hospitals. But to be able to actually have a treatment we can give to those patients, like we do patients who are having a heart attack in front of us, or those that are bleeding out, we have great treatments for those. It would be amazing to be able to do that for stroke patients as well. So that's what we're trying to do. At the moment, we're collecting just blood and saliva samples. The blood samples being tested at the University of Birmingham labs, which Tony will talk about a little bit more later on. And then the saliva samples are going also to university, but a different area of the university. The saliva is what we're looking at to find the biomarkers that we hope we're going to be able to find. We're looking for microRNAs. And then the blood is extra work that's John Hazelden's doing, who we said unfortunately isn't here today, looking at seeing if he can predict the severity of strokes and patient outcomes and further work on that. So it's a really big project. Just an update for you, we've recruited our 49th patient this week. We're looking at a target of 200. So we're doing really well. We're on target. The ambulance crews are really joining in with this, and I'm sure Josh will talk more about that later on. So that's our overarching aim. That's what we're here for, and I hope you all enjoy the rest of the webinar.
Thank you so much, Hazel. Just a reminder to our audience, if you've got questions about anything Hazel's just said, or anything anyone else says during this webinar, you can pop your question in the LinkedIn chat and we will get to it in the Q&A segment at the end. But next up we have Josh. So you're going to tell us about how healthcare professionals can get involved with GHOST.
Yeah, absolutely. So as I said at the start, I work at West Midlands Ambulance Service, but it's not really me doing the research, it's our frontline crews. So our emergency paramedics out of our Hollymore ambulance station, which is in South Birmingham, have signed up for the GHOST study in good numbers. There's almost 70 already, but we're very happy to have more paramedics join the study. They've joined, and they are the people who gather these samples from patients with suspected stroke. I'll talk a little bit about that in a moment, but I think it's important in case we do have any either clinicians or patients and public watching this call, just to confirm that none of this changes anything about how we expect callers to recognise stroke. So the test that we advocate in the UK is the FAST test, which stands for Face, Arm, Speech Test. So there's three elements to that. So first thing is we're looking for facial symmetry. So looking at someone's face, ask them to smile and see if it's any drooped on one side, if they can do that smile evenly. The next thing is if you ask them to hold out their arms. So the arm test is holding out their arms in front of them. You need to give this a few seconds and you might see a little bit of a drift on one side, or you might see that one arm is completely flaccid. Again, if there's some asymmetry there, we might be suspecting stroke. And the third point is speech. So speech might be slurred in the case of a suspected stroke, or people might not be able to name and recognize common items. So you might hold up a pen or a key and they not know what it's called. If you see any one or more of those signs, it's time to call 999. Stroke is a medical emergency. Don't overthink that. Just make that call to 999 and speak to us and say that you suspect the patient's having a stroke. So nothing has changed about that. The changes within GHOST are from when the crew arrive. So what will happen when you call 999 is the call assessors will take some questions, ambulance crew will arrive, and because stroke is an emergency, they'll be coming on blue lights and sirens, so don't be worried about that. The test that the ambulance crew is the very same one that I've just described, so a FAST test. Now the FAST test is quite a sensitive test, so it's quite good at identifying stroke that needs treatment, but it's not particularly specific. So as Hazel mentioned, it can be bringing in some false positives. So what we're hoping is that we will be able to increase that specificity, so try and rule out some of those. The reason why we think this is important is threefold. There's three people who'll benefit from going to the right hospital the first time. The first and most important is our patients. So if you think of a patient in Sutton Coldfield, north of Birmingham, that patient might well be taken with suspected stroke, perhaps an hour away from their home to the Queen Elizabeth. They might still end up as an inpatient there, even if they have a condition that's a mimic of stroke, so something that looks like stroke. They might still end up there. It's more difficult for their family to get to them. It's further away. It's not a familiar hospital to them. So if we can get the patient to the hospital that's closest to them, it's better for them. It's better for their loved ones. The second point is that the hospital teams who deal with stroke, they do deal with large numbers of conditions mimicking stroke as well. By being able to identify at the scene that this is not likely to be a stroke or it is likely to be a stroke, they'll have a better ability to focus on those patients who do have stroke. And the third thing is ambulance crews. Now, ambulance crews do not want to be going an hour away from where their patient's been. Just the same as the patient, they want to take the patient to the nearest hospital if that's appropriate. The thing with the stroke units is that some hospitals are stroke units and some are not. We know that we get improved care by concentrating resources in specialist stroke units, but equally we want to, where possible, bring only patients with stroke to those hospitals. So that's a little bit about why we think this is important to help patients. I promised that I would tell you a little bit about how these samples are collected, and I'm actually going to demonstrate that today as well. This might go a bit wrong, so bear with me. So first of all, we've got the ghost pack here. So the ghost pack consists of two things. That the main thing we're speaking about today is saliva, so a saliva swab taken from the patient's cheek. Also, there is a little bit around some blood samples, so blood samples taken in these containers here. So that's when a patient's having a cannula placed, a little needle into their arm or their hand. They have some blood samples taken at that point as well. The ambulance crew are doing these, and they're doing them at the time earliest possible in the patient's journey. So they'll be doing this at the scene with that patient. But I know people might think, well, is this going to slow down my care? At this point, we're developing a lateral flow test. We're not waiting for the results. All we're doing as the ambulance teams is taking the samples so that the people that Hazel and Tony are going to talk about can hopefully develop a lateral flow test for the future. If you want to see how quick this is, I'm just going to demonstrate it now. I'm going to put myself on mute so you don't get a load of noises, but this is how long it takes. A moment of terror when I couldn't get the cap on the thing then, but essentially we're looking at sub 30 seconds, which could be done with alongside other work. So while while the crews might be fetching a carriage air, for example. So that sample then goes with the patient to the hospital. Because this is an emergency, we're not consenting patients or their families at the time of the sample being taken. Stroke is a minutes count. Millions of brain cells are dying each minute during stroke. So instead, we are taking that sample, and the hospital staff will be speaking to the families after the fact. So later on, once the initial emergency has passed. Those patients are taken to the Queen Elizabeth Hospital, which is a stroke unit either way. So there's no change in practice in terms of the destination of these patients during the GHOST study. We hope that in the future there may be a test that can say this is a stroke, this is not likely to be a stroke, it's likely to be a mimic. But at the moment, I want to really emphasize there's no change in destination for these patients. Really grateful to the paramedics who are taking part already, almost 70 paramedics taking part in the study, but there's plenty of more room for more people to join. Just get in touch with me. And I just want to end by saying a real big thanks to all the people who've donated to the Stroke Association to fund this study. Thank you very much.
Thanks, Josh. I noticed when you were doing that lateral flow test, that is actually shorter than a COVID lateral flow test, which I think we're all grateful for if we ever have to do a swab test again. Moving on to Tony. So you're going to tell us a bit more about the different samples that are being taken by the ambulance crews, and you're also going to tell us more about the bigger picture of what GHOST could mean for the future of stroke care in the UK and around the world.
Yeah, thank you very much, Claire. I think the crews are also collecting blood and urine once the patient is in hospital, and this is because, in a way, we're very grateful to the Stroke Association, people they've donated, also very grateful to the patients that clearly participate in the study, although we're not seeking consent, and it doesn't mean we shouldn't be grateful for their time and for advancing stroke research. And really, we want to get the maximum benefit from recruiting patients, and also because the paramedics are taking time to recruit. It's not very long, as Josh was saying, but it's still something that is not part of their routine. So we're also collecting blood and collecting urine because as well as looking for microRNAs, which Hazel has alluded to, so genetic biomarkers, if you like, we also banking the samples where we're looking at these things in saliva as well as blood as well as urine. Because at this stage, it's probably fair to say that we don't know what we're going to see. MicroRNAs have been identified in blood following stroke, so we know they're there, right? We don't have to guess that, but it's never been done in saliva before, as far as we're aware. So we're hoping that will be available in saliva, because saliva, as Josh has beautifully demonstrated to the world, saliva is really, really quick to get. You don't need a cannula, and potentially, obviously, we're talking about paramedics attending to its potential stroke victim, but it could be, somebody else with no training at all if you're using saliva. Whereas for blood, you would need someone with phlebotomy skills. It's not really the best thing. And also, blood is messier than saliva, and some people you cannot cannulate because they haven't got the right the right veins. I'm not trying to blame the patient. What I mean is it's not as straightforward as getting saliva. You can get saliva more or less out of anyone. So we're looking at biofluids in general. We're also not just looking at genetic biomarkers, but we're banking the samples, because people may come back in the future and say, we found a protein biomarker that we would like to test in your samples. And this is obviously, we have the moral duty to make the samples available to people that have some really exciting discoveries that need to be tested on things that have already been biobanked and phenotyped for other groups of people. And also, particularly, obviously, it's unfortunate John couldn't be here today, but he's looking at specifically signs of inflammation in the samples. And this is really important because we know that inflammation in the brain and systemic inflammation in the body, for example, people that have a chest infection or urine infection, that stroke volume seems to be greater. So the inflammation is a mechanism that seems to amplify the damage following stroke. So whether the inflammation is present in the body or whether it becomes present in the brain following stroke, we know that if we can perhaps modulate the inflammatory response, maybe we have a way of reducing the infarct size. So the volume of strokes means the number of cells lost following stroke. So this is specifically the area that John is looking at. And before the work that we've done with John actually has identified, these inflammatory changes in people with other conditions, and Hazel has alluded to trauma, but people have surgery, whatever. These inflammatory changes happen really, really quickly. So there's not like, they take a day or two to develop, and so it really is important to have a look in the early samples. And the beauty of what we do is actually, these are really ultra early samples. And a bit like what we did for trauma patients, there are a number of things that people kind of knew from animal studies but never been seen in humans. But once we started collecting samples from the roadside and people that had road traffic accident, for example, we could see that these changes are also present in humans, and they're really ultra early and potentially amenable to treatment. And this is why this is important. So I think in a way, there's a practical element trying to find a test that can help direct patients and, like Josh has said, triage patients appropriately, send them to the right place with the best treatment, and not really overburden units that are not, they're not designed for stroke mimics, for example. And also possibly instigate early treatment as well, but also in terms of, research benefits, helping answer, sort of broader questions, different questions, and ultimately, leaving the samples available as a legacy to other research groups that, have other, exciting ideas to test. You also asked me about the implications for, the global implications, if you like. And I think this is something that we feel really, really passionately about, because as you heard before, I think, in the UK, we have stroke units, you have hyperacute stroke units and stroke services set up in a number of places, and they're very good. They really come along very, very strong. We think of the bigger picture, the big world out there. In many places, it's fair to say there are no hyperacute stroke units. There are probably not even stroke units, and there are probably no stroke services. And in fact, we think about how a stroke could, someone with a suspected stroke could be directed towards a CT scan, or maybe not if it's not a real stroke. We probably sometimes we're not aware what that means in certain geographical contexts. For example, having a scan means sometimes you have to sell something because you haven't got the money. You have to borrow money from your friends, from your relatives. Your kids will stop going to school because you haven't got the money. And if you do need stroke care, fair enough, because it means potentially saving a life or being able to return to work if that's amenable to treatment. But if you don't, that's really huge implications, and people don't live near a sort of hospital facility or whatever. So potentially, in the big world of that, which is much, much bigger than the UK, or the Western world, as we call it, there are potentially, billions of people that, and I'm not trying to make it sound too big, but potentially will benefit from a test, can at least help with the initial triage. So if you need a scan, yes, of course you do. But if you don't, you don't have to necessarily have to sacrifice, your assets, or penalize your family just to find out what the answer is. So I think obviously the Stroke Association is a UK-based charity. Charity begins at home, but we have to think, perhaps other context in mind that just as important.
Absolutely. I think obviously, yes, there are real benefits that could happen in the UK as well. I remember when I first heard about this project, I thought of where I grew up, which is rural Cornwall. And if someone has a stroke in that village, you've got, you can go in one direction to a hospital that doesn't have a thrombectomy centre but is closer, or you can go the other direction to a hospital that's further away that does have a thrombectomy. Like, how do you make that decision?
True.
Yeah, that obviously that was the first thing that occurred to me because of my personal experience. But yeah, absolutely, it could be a real game changer for so many people around the world if you can know without a brain scan, because that is the only way you can diagnose a stroke at the moment.
Yeah,
whether a stroke is actually happening.
And stroke is a pathology that is on the rise worldwide, and it's not. And people, we think of stroke as something associated with aging, but it's really not true. I mean, obviously there is a peak of prevalence in older age groups, but people at any age, including children, can have a stroke. And actually, perhaps I would say, is just as important, or even more important, to in a way have a test for somebody where stroke is a rare occurrence. Because I think if you have, and Josh elegantly presented the fast signs, but in a child, if you could have a test that could confirm something unpleasant happening in the brain, Those are the ones that they're often missed because it's less common, right? So you really want to, have a test that you say, well, it's just, it's a saliva test and it's not going to take very long. Let me do the test. I don't think it is, but let me check. It is probably, so probably the gain is even larger than in someone we think, oh, this is somebody who should definitely go to a hospital. Yeah.
Yeah, absolutely. I also wanted to ask you a little bit more about Scrum, which Hazel mentioned earlier. So that was a similar study, but on concussion, right? Could you tell me about that?
So we started looking at macroRNAs a sort of while back, and actually it's probably go around full circle because we studied, interestingly enough, we studied with subarachnoid hemorrhage, which is a form of stroke, effectively, many years ago, and then we found that macroRNAs were present in the cerebral spinal fluid of people with subarachnoid hemorrhage, and then started looking at in blood, and then because of our instance in trauma, we started looking at people from the sister study, the golden hour study that Hazel has alluded to, and we could find that macroRNAs were present. It presented significant changes in blood immediately after a head injury in people with a certain severity, and this is really remarkable because before we just assumed these changes would take some time. And because I work with the military and with sports associations, in a way, the question was very much, okay, this is great, but it's blood, right? So we're not, blood is, as I said before, it's not easy to get if you're close to a rugby pitch or in a remote area in Afghanistan or whatever. So what else can we do? So we started looking at saliva, and to be honest with you, we didn't know what we were going to find. So we found that macroRNAs were also present in saliva. So we partnered up with the Rugby Football Union, did a study on elite rugby players from the top two tiers, so the Premiership and the Championship, over a couple of seasons. And the rugby players are assessed at different times. But for everybody who follows rugby, there's an assessment done on the pitch for the majority of them, and then after the game, and then after 2 nights, effectively. So we could see that these macroRNAs were different in people that had a concussion immediately after the injury. And this is really if you want, the startling discovery that these don't take hours, but if you take a player and then when they go out for an assessment, which is it has to be completed within 10 minutes of a suspected concussion, these macroRNAs were telling us a story. They were telling us who had a concussion versus people that passed the assessments, or people that just played in the match, or same thing like dehydration, match stress, or sleepless nights before or after, people that had musculoskeletal injuries. So the macroRNAs were very specific to the concussion, and they were present immediately, and those changes were present for several days. So really thanks to Hazel, so we published this study called the Scrum study in the British Journal of Sports Medicine, attracted a lot of attention because people really are very keen to sort out the problem of concussion in sports. But Hazel really came to me with a call from the Stroke Association around biomarkers and technologies to accelerate diagnosis, and this is how it all started. So really thanks to Hazel for making that connection. And if you think about it, it is really the most logical extension of the Scrum study, because you have different problems. All right, I mean, stroke is obviously far more serious than a concussion, but it's still a form of brain injury. And if we can see it in saliva for a concussion, which is in a way a much milder form of brain disturbance, that's why that's giving us hope that we can gonna find something useful in stroke, where the volume, if nothing else, of the brain affected is much larger. So this will give us confidence that we should go and look in the brain. And again, a bit like concussion. Years ago, we used to say, okay, you've been concussed, and fine, just go and rest and do nothing for whatever. But it's not true anymore. And the question is very relevant, particularly to grassroots, where you think people should come back and train the following day, or should follow sort of graduated return to play protocol, or have access to targeted treatment. We know if you don't treat players correctly, they can take a lot longer to recover. In stroke years ago, when we didn't have those fast, time critical treatments, it probably wouldn't have mattered so much. But now we know that actually treating stroke in a timely fashion with, with thrombolysis or thrombectomy makes a huge difference in outcome, or even a, decompressive craniectomy or whatever. So it is not, again, I think it's a sort of the two things going hand in hand. If you don't have a fast way of diagnosing it, then the other questions become less relevant. What will you do about it? But once you have a test, I think that maybe there will be even more developments in terms of offering, different management modalities. An example that I can give you is just recently, again, the question whether we framed some of our research around, or not just diagnosing stroke, but as you've alluded to, Claire, I mean, hemorrhagic versus no hemorrhagic stroke. And again, to some degree, I think, well, it doesn't matter, because you got to find out once the patient has a scan. But now recently, and this is from the summer, that we know that the guidelines have changed. So if you have a hemorrhagic stroke, you keep the blood pressure a little bit lower. If you have just a purely ischemic stroke, you keep pressure a little bit higher, because actually that makes a big difference in terms of outcomes, a measurable difference. So even knowing that, and again, is something that we didn't know before, but in a few months, things have changed. I think even, things that perhaps were not relevant a few months ago now have become relevant. And we don't know what the future brings. It could be that around the early diagnosis, might follow sort of, new diagnostic modalities or treatment modalities or different treatment algorithms that are based on, the parameters that we can offer. Yeah.
Amazing. Thank you so much, Tony. I'm just going to open up our Q&A segment now. So I realise our audience might want a bit of time to think before they send questions in. So I've got a few questions to start off with, just to get the ball rolling. That'll give everyone a bit of time to think and type their questions if they'd like to. My first question is for Hazel. So you talked about, Tony also just talked about the test potentially being able to tell the difference between a stroke that's caused by a clot, which is the majority of strokes, and a stroke that's caused by a bleed, because they require very different kinds of treatments. Might it also be able to tell whether someone's had a TIA? So just quick explanation for our audience in case you're not familiar. Transient ischemic attack, essentially a clot in the brain that causes the symptoms of a stroke, but unlike a stroke, it resolves itself fully within 24 hours. Hazel.
Yes, I'm going to thank John for this in his absence, actually, because we've discussed this amongst ourselves. The answer is yes, potentially. The thinking is maybe that the TIA will present slightly different biomarkers to the stroke, or it will be that they're much shorter lived. Now, my understanding of the definition of a TIA is that it resolves itself within, I think it's 4 hours. I might be wrong there. Anybody correct me if I've got that wrong. So the good thing about what we're doing is, because we're getting the samples so early, and then we're also taking follow-up samples. So we are doing them at 4 to 12 hours, 48 to 72 hours, discharged 3 months, 6 months, and a year. So the hope is then that if there is something that's showing up that's really early, that's then disappeared later on, which is exactly what we found in our golden hour study, that there are certain things that are there within those first 60 minutes of injury that have gone by the time the patient even gets to hospital, that may then be the guide to tell us that it's a TIA, along with the symptoms resolving, within that time gap. So yes, definitely potential.
Thank you so much, Hazel. I always think that's really interesting, because obviously at the point when you come in having a TIA, you don't know it's a TIA. Then you won't find out until sometime down the line. But yeah, if there's something that the test can do to help figure that out earlier, that would be fantastic. Okay, my next question is for Josh. What do ambulance crews think about the GHOST study?
They love it, actually. So this has been a lot of my job is encouraging people to take part in research, encouraging ambulance clinicians, so paramedics and technicians, to take part. But this has been one that I put out a few adverts and there was people champing at the bit. So it's been relatively straightforward to get people to take part. I think the reason for that is that a lot of ambulance staff and hospital staff alike would recognise that stroke is very challenging to recognise. The stakes are incredibly high if you miss a stroke. And with that in mind, we have a relatively sensitive but perhaps non-specific approach for recognising stroke. but equally that's frustrating if you have either sometimes some quite complicated discussions over the phone to try to ascertain whether someone's having a stroke or not. That can be difficult. The other thing that's a challenge is if we're going in some occasions quite significantly longer distances to get to the stroke unit, and then finding out that this is not a stroke, that's just, I said it earlier, for all three people involved, the patient, the ambulance crew and the hospital, that's really disappointing. So they've really gone for it. We've had almost 70 paramedics so far. That's at one ambulance station. So we're running out of the South Birmingham ambulance station, Hollymore, which is the only station in the West Midlands taking part. And the reason for that being that we need patients who are going into the Queen Elizabeth staff of the research team taking part, and the University of Birmingham providing the academic support. So it's only going to be at that ambulance station, but we're really excited. And if there are any people watching from Hollymore Hub who have not signed up yet, then do get in touch with me.
It's so good to hear that people are keen on this. That's always what you like to hear as a researcher, right? Oh, that's wonderful. Okay, I've got one last question from the pre-prepared ones that we did, and then I will move on to our audience questions because we've had a few come in now. So lastly, for Tony, so this is a test that's currently done in a lab. If that all works out, how long do you think it might take to get this to being a point of care test rather than something that's sort of being done in this context?
Yeah, and probably, I mean, it's a really good question, because we really would like it to be totally point of care in the back of an ambulance. Currently, it's done in the lab. But if we take COVID as an example, but this type is based on PCR, which I think before COVID, very few people knew very much about. Now everybody talk about, eloquently. PCR before COVID, it would take, it's a lab 8 to 10 hours to turn around. And, during COVID, it got down to 20, 30 minutes in some labs. And I think it's driven by necessity, if you like. Before we didn't have the need to have a rapid PCR test. Now we did. And the same thing happens, with sort of concussion or whatever. Before there was no need to have a test. So the technology is getting faster and faster. We have been in contact with a number of companies and technology suppliers, if you like. They have potentially have the technology to make this available within minutes. But it's really, I think the first step is to show that it can work, and this will drive the technological changes around us. So with the companies that we've been working with or have been in dialogue with, I think potentially all these applications could give us the answer. I don't think, if I can be brutally honest about our own research, I think this is not a quick process by any stretch, because even if you can do it within 5 minutes theoretically with a new technique that is not currently available, it still takes a long time for that to be validated, to be regulated, to be approved, and to be adopted. So I think the process is very long for any new test. If this works, and we hope it will, then potentially this will give impetus to this whole field of research, and potentially this will bring a nice some bunch of clever people to the table to make this readily available. And then actually what we've seen through the Stroke Association, there's a lot of enthusiasm for this kind of research. So I think those could catalyze potentially new solutions that we haven't even thought about. So, but the process is going to take a long time. So I'm not under no illusion it's going to be sort of years rather than months. I would love it to be months, but I don't think it's going to happen that quickly.
Yeah, absolutely. I think we all know as researchers, or former researcher in my case, research takes a long time. You want to be sure you're getting it right, especially with something like this. That process is slow because it's important that you have to get it right. Even years from now, that's not too far in the future. We're not talking decades. We're talking fingers crossed.
As I say, the best time to plant the trees 20 years ago, the next best time is today. So at least for a starter, right?
Yes, very good point. Okay, we've got a few audience questions. The first one of these is from my colleague John Watson. So he said, I work for the Stroke Association and we're often challenged by people who have had strokes but did not show the fast symptoms. Would a saliva test be cheap and simple enough that it could be readily available in GPs, pharmacies, etc., so that it could be used with people showing balance, dizziness, headaches, etc.? Could be used for people who are probably not having a stroke, but for whom there is some chance that they might be. I'm not sure who would like to pick that up, if anyone.
I'm happy to pick up because I think it's a really, really good point. And actually doing the study, and Hazel will back me up. We've actually, one of the questions that we had when deciding the inclusion-exclusion criteria is that what happens to people who present late? Because obviously, in terms of biomarkers, we need to make the window a little bit narrower so we have consistency in our results, because these biomarkers can change over time. But actually, we realized a lot of people present late, and not everybody calls an ambulance. Not everybody goes even to their GP, and these people are still important to diagnose correctly, because there could be a sentinel stroke that kind of heralds a much bigger event, a few weeks down the line, for example. So it's really important that people have the test available. And for the concussion study is exactly the same. We imagine the test will be available in the community through pharmacies or treatment centers or whatever, because yes, I think people that are alert to the possibility of a stroke will call an ambulance, but there'll be cases where you think, you speak to a friend and thought, maybe you should go to see a doctor because you may have had a stroke, last weekend where your speech became a little bit slurs. So I think these are things that happen in real life, and we would really want this test to be available in the community, not just in the hands of, healthcare workers.
Thanks, Tony. Hopefully that has answered your question, John, but just so people are aware, we're also going to take any questions we get that we're not able to answer today, and also all the ones we have answered, we'll pop them on our website with a recording of this webinar so people can read through afterwards if they'd like to as well. Okay, next question is coming from Philip Bath, who I believe is also a stroke researcher. That name looks familiar to me. Yes, this makes sense following on from what I've just said. Having tested blood biomarkers for stroke for 3 decades, we've struggled. Concussion at rugby is straightforward since you know the cause for any changes, but 50% of strokes are actually mimics, many of which alter blood biomarkers in the same direction as IS and ICH. Do you think your biomarkers can separate stroke from seizures, infections, etc.?
Well, I think this is exactly what we're setting out to explore, and I think it's we want if the test works, is exactly what we're hoping it will do, because as Josh has alluded to, I think fast is a good tool, but it has a lot of false positives. In fact, it's effectively specifically is all about it's less than 20%. So you can argue that almost like a yes machine to some degree, but the accuracy is about 40% because of stroke mimics. Now, the thing that what is a little bit different about this type of biomarkers, actually, you don't get a single biomarker that tells you the full story. It's a combination of biomarkers, and it's because it's almost like playing a piece on a piano, for example. If you listen to just one note, you're probably not going to guess what it is. If you look at them in combination, a particular sequence, you're going to guess the tune. So these microRNAs act in concert. So some will go down, some will go up. Once you do that, it becomes a signature of a specific injury. So with concussion, for example, you have a lot of players that don't actually have a concussion. So at the bottom of a rock, for example, they nobody knows what's happened. And when they do the standard procedures, maybe they say, they fail the test because of, much stress, because of dehydration, because they were, nervous or whatever. So they didn't actually have a concussion. Equally, the way we tested it, and, we didn't want, a lot of this biomarker research has been affected by, for example, other things contaminating your samples. For example, in the instance of trauma, you get sometimes a musculoskeletal injury that causes inflammation that produces similar biomarkers to what you see in a head injury, for example. But actually, what we've done in our test is really that separation worked really, really clearly. So we could tell what was a concussion, what was not a concussion, what was just pure, dehydration, max stress, what was a musculoskeletal injury, with about 95–96% accuracy, just based on the saliva test. So it's what it means. Yeah, the separation is quite good in a way, but is not having to look at more than one marker also causes different challenges, because you can't just measure one thing that goes up or doesn't go up to diagnose stroke. We've got to, in a way, you've got to use AI, you've got to use other techniques to work it out. So it takes a little bit longer, but when you do that, you have a unique signature. So we hope this is going to go the same way.
Thank you so much.
Can I just add something on that, the end of that, just in singing the praises of the West Midlands Ambulance Service paramedics, really, that in Philip's comment there, and he said about 50% of strokes are actually mimics. That's exactly what we've seen in our patient population, in our 49 patients. 50% of them strokes, 50% of them have been mimics. Just to add that in there, I just thought that was interesting.
Thanks, Hazel. Okay, next question. I think this might be one for Josh. So Jessica has asked, how readily do you expect other NHS trusts to implement this tool? And do you think uptake might be slow in certain parts of the UK, even if it's proven to work?
That's a really good question. So if we start with me talking about this being implemented in ambulance services, there's a couple of things that are important to understand. So the first thing is that we're very keen for this, and actually we've seen with other tests, other diagnostic tests and treatments, that ambulance services tend to go for things before the evidence base is even well established, and generally in pre-hospital care people will start going for various treatments before there is an established evidence basis, and this is not a problem that we see of slow uptake. The other thing, and this is really important, twofold really. The first is that it's probably a bit of a simplification to talk about this as a test that will say stroke versus mimic. It'll be in combination with a history and a clinical discussion, most likely. The second thing is that the ambulance services in England, I'll talk about England, Welsh and Scotland, ambulance services devolved and they have a whole ambulance service for each country, so the same principle applies, are very large. So we have 10 ambulance services in England, which cover multiple hospitals. So in the West Midlands, we have covered several dozen hospitals, of which some are stroke units, some are thrombectomy units, 2 providing 24/7 cover and 1 aspiring to extend their hours at the moment. And it's likely that different receiving units will take different thoughts about the values of any given diagnostic test. We do work to try to homogenize, so try and get the same approach for something like a fast alert that will all alert patients within a certain time frame who've got certain symptoms. And we've done that to a lesser or greater extent, but it probably will be a little bit of variation in terms of the hospitals receiving those patients, whether they think much of any given test or not. However, the ambulance service will have a unified approach to that. So our ambulances are made ready. I could walk onto one with my eyes shut and put my hand to anything in it because they're made ready to a spec. They're sealed up by our wonderful vehicle preparation operatives. Do a fantastic job. So if tests go onto one of our ambulances, they'll go onto all of them. I hope that answers that question.
Very much, Josh. Got another question coming now. John has asked, what are the economic impacts, positive or negative, of having a test such as this readily available for use? And is this something that's being investigated? Ooh. Tony, would you like to take it?
I'll briefly say secondary transfers for patients who go to the wrong hospital accounts for about around about £2 million a year for us in the West Midlands alone. That's all conditions, so major trauma, heart attacks, all sorts, but it's a big thing. So get it right first time.
Yeah, and what is difficult to measure is the impacts on other services as well. So if you have somebody, particularly with the congested emergency departments we have now, and the the ambulances in, queuing up outside a hospital. Having one patient who's in the wrong place will affect everybody else, down the chain, particularly if it's a high priority case. So those are more difficult to measure. So following this, we will have a phase 2 study where we're going to look at health economics more directly. Obviously, this is more exploratory, but the health economics impact is a really important question. So we are preparing to embed it in the next iteration, and the way that we're asking, for example, the questionnaires and the outcomes are also to test the feasibility of doing health economics later on.
Thanks, Tony. I think this is something that it can be easy to forget at the sort of early stages of a research project when you're trying to sort of figure this kind of thing out. There will come a point when you have to figure out what this looks like and what it means in the real world. I often think that oh no, I completely lost the train of thought there. Another question came in while I was talking. I don't think what I was going to say was particularly important, just a reflection on something you said. But the question that has come in, I think probably one for Hazel, this one. What happens if someone decides they don't want their sample or their loved one's sample to be used once they're in the hospital and the staff there have explained what the project's about?
Yeah, I think it's just important to mention, actually, this study, as well as every other study we run, has a full ethics approval before it's even started. And just to explain, that's called a Research Ethics Committee, or a REC. There's several around the country, and there are some that actually specialise in approving projects that require patients or us to recruit patients who don't give us consent before we recruit them to the study. So obviously this has been through that. They have agreed to us obviously being able to keep the samples up to the point that the patient withdraws, and whether that's the patient themselves withdrawing, one of their treating doctors withdrawing on their behalf, or a family member doing it. So we will keep everything up to that point. We keep all data up to that point, and then we don't take anything else afterwards. We haven't had many withdraw, and we haven't had many object. The main reason is actually because they don't want to be bothered once they've gone home. They're going on with enough, they've had this massive, sometimes life-altering event happen to them. So it's, we just accept it and say, thank you very much, we'll keep what we've already got, and that they're, yeah, that's absolutely fine. Nobody has ever objected to that. And so most of them actually are more than happy. We do find, this might be off track a little bit, but we do find actually that patients generally are happy to agree than their relatives. I think relatives find agreeing to something on somebody else's behalf much more difficult. But we obviously have to follow the process. We have to upgrade consent as we can, and we would much rather get some consent from the family, or them say, actually, no, I don't think this is suitable for my relative. And then, at that point, we will pull back. But once that patient said, yes, I'm happy, then their consent is the overriding one.
So I think one other thing that is important to say here is, as with all of the research projects that we fund, the process of your research has been developed with people affected by stroke. So there are people who've said, based on my experience as someone who's had a stroke, or as someone whose loved one has had a stroke, this is what I would feel comfortable with. So yeah, we're not going, this is research that is happening without any involvement from stroke survivors. That is at the heart of everything we fund, and therefore with this research project. So I know that this is something you would have thought about really carefully before the project began. Well, we are coming to 25 past, and I don't believe we have any more questions, so I am going to wrap it up here, unless there's anything any of you would like to add to what you've already said.
Just a huge thanks to everyone who's donated, and also the paramedics and the patients taking part.
Absolutely, and I like all that, and also thanks for the questions. And I think if you, particularly for the next phase, is obviously if what we're hoping to find is confirmed, and there will be obviously, having stimulating questions is incredibly valuable, because ultimately, I think the people that, for example, have attended these webinars will be end users or or people involved in the implementation or whatever. And I think having, this, stimulating or even challenging questions upfront is going to make us say, get it right.
Well, I'm going to wrap it up there. So if any of our audience would like to know more about GHOST or the other research the Stroke Association funds, you can read about it on our website. We've posted links in the chat throughout this session. If you are someone affected by stroke and you need information or support on any of the topics that have come up today, there's lots of information on our website again. You can also call our helpline on 0303 3033 100. It's open 9 till 5 Monday to Friday and 10 till 1 on Saturday. Or you can email the helpline team on helpline@stroke.org.uk. So all that remains for me now is to say thank you to Tony, Hazel and Josh. Thank you, Jack, for your tech support in the background, and thank you to our audience for watching and asking questions.
Thank you, Claire.
Bye.